Greetings. My name is Mathieu and I am a medical student at the Northern Ontario School of Medicine. Thank you for providing me with the opportunity to present at the 2020 Northern Health Research Conference. This study, influenza vaccination blunts the inflammatory response in patients undergoing cardiopulmonary bypass, was completed under the Division of Cardiac Surgery and the Department of Anesthesia at Health Sciences North. The corresponding author and principal investigator of this study is cardiac surgeon Dr. Mathieu. Acknowledgements and Disclosures. This study was supported by a grant for the Northern Ontario Academic Association Clinical Innovation Fund. This study was presented at the American Heart Association meeting in Philadelphia and at the Society of Thoracic Surgeons meeting in New Orleans earlier this year. The authors of the study disclosed no conflicts of interest. Background. Patients undergoing coronary artery bypass grafting, commonly referred to as CABG, with cardiopulmonary bypass, or CPB, have an increased systemic inflammatory response, or SIR, that predisposes patients to post-operative complications such as myocardial injury and major organ dysfunction. The SIR is caused by increased levels of cytokines and acute phase reactants such as C-reactive protein, interleukin-6, interleukin-8, and tumor necrosis factor. Currently, no drugs or interventions have shown to reduce the severity and negative effects of this inflammatory response. Recent studies suggest that the influenza vaccine may decrease the risk of atrial fibrillation, sepsis, and major adverse cardiovascular events, MACE, such as stroke, myocardial infarction, and cardiovascular death. For these reasons, both the American Heart Association / American College of Cardiology and the European Society of Cardiology recommend the influenza vaccine annually for individuals with established cardiovascular disease, or CVD. Although the mechanism is complex and not well understood, recent studies have shown that the influenza vaccine exhibits cardioprotective properties by attenuating the inflammatory response seen after myocardial infarction. Interestingly, this phenomenon persisted beyond the flu season and irrespective of an active influenza infection, highlighting the prolonged systemic effect of the vaccine on the inflammatory response. Rationale. CPB is a common procedure in cardiac surgery which triggers a significant increase in inflammatory mediators, activates leukocytosis, and produces oxygen-free radicals, all of which are associated with a sustained SIR intraoperatively and postoperatively. This chain of events can lead to postoperative complications such as respiratory failure, renal impairment, atrial fibrillation, neurological and liver dysfunction, and potentially multi-organ failure. In patients with CVD, the influenza vaccine has been shown to decrease cardiovascular morbidity and mortality via its anti-inflammatory properties, warranting interventions aimed at reducing the SIR to CPB. Given the clinical implications of inflammation during CPB and the potential role of the influenza vaccine, we hypothesized that vaccinations in patients undergoing CABG, or CABG, would result in a reduction of the inflammatory markers induced by CPB and would attenuate myocardial injury. This may ultimately lead to improved postoperative outcomes for patients. Methods. This single-center, prospective, double-blind, randomized pilot trial was approved by the Health Sciences North Research Ethics Board. Informed consent was obtained from all participants. Patients over 18 years of age referred for in-house CABG between November 2016 and January 2018 were assessed for eligibility. Patient selection is displayed in Figure 1. After the eligibility assessment, a total of 30 patients blinded to the treatment were randomized into experimental group 1, which received the influenza vaccination, and the control group 2, who received a placebo vaccination. Both groups comprised of 15 people. Vaccinations were given 4 to 7 days prior to surgery. Serum samples. Serum samples of pro-inflammatory mediators, as well as the anti-inflammatory marker interleukin-10, were taken as followed. Before cardiopulmonary bypass, 5 minutes after cross-clamp removal, at the end of cardiopulmonary bypass, 4 hours postoperatively, and on postoperative days 1 and 2. Troponin concentrations were measured under the same parameters to assess myocardial injury. Further assessment of myocardial dysfunction was investigated by measuring hemodynamic and echocardiographic data. All who were responsible for assessing patient data and post-operative events were fully blinded to all outcomes. Results. Patients in both groups had similar preoperative characteristics, including CPB, cross-clamp times, and medications. As depicted in Figure 2, an increase in the baseline levels of IL-6, IL-8, and TNF was seen in vaccinated patients. Although this group had higher levels of pro-inflammatory cytokines at baseline due to the vaccine itself, this reaction was much lower than the inflammatory response induced during CPB. In both groups, all cytokine levels increased during CPB, and the peak level of pro-inflammatory markers was reached towards the end of CPB, or 4 hours after. However, patients who received the influenza vaccine preoperatively had a statistically significant lower levels of IL-8, IL-6, and TNF at different time intervals, including at the end of CPB, and 4 hours postoperatively. Interestingly, this lower peak of pro-inflammatory markers persisted for 1 to 2 days postoperatively. CRP levels had a lower peak in vaccinated patients, but this did not reach statistical significance. As a quick summary, mean interleukin 8 is on the top left, mean interleukin 6 on the top right, mean TNF alpha on the bottom left, and mean CRP on the bottom right. In contrast, anti-inflammatory interleukin 10 levels were significantly higher in vaccinated patients, which persisted for 24 hours postoperatively. Both groups had similar troponin concentrations at baseline, but levels started to increase at the end of CPB, peaking 4 hours postoperatively. Postoperative troponin levels were lower in patients who received the influenza vaccine, which persisted for up to 48 hours postoperatively. As expected, due to the small sample size, no differences in postoperative outcomes were noted between the experimental and control groups. I've created a summary of the results that I have just explained, only to be displayed in greater details. Feel free to refer to this slide for a greater understanding of the results. Limitations. The limitations of this study include a small study sample size and a lack of understanding of the complex pathophysiologic conditions that regulate the inflammatory response seen in patients undergoing CPB. Both the experimental and control group were well matched, but there may be other variables that might influence the systemic inflammatory response. Additionally, the timing of the vaccination and its effect on the acute reaction is important, but remains not well understood. Further, this study did not identify clinical outcomes and hemodynamic changes, such as the incidence of atrial fibrillation, stroke, or graft occlusion, which are all related to a decrease in the inflammatory response. Final thoughts and future directions. To the best of our knowledge, this study is the first to test the use of the influenza vaccine prophylactically in patients undergoing cardiac surgery. When administered preoperatively, it attenuates the early systemic inflammatory response and myocardial injury seen after cardiopulmonary bypass by decreasing pro-inflammatory mediators and increasing anti-inflammatory interleukin 10. There was a clear trend towards improved cardioprotection and early metabolic recovery, as seen by a decrease in the release of troponin and improved hemodynamics in the vaccinated group. This preliminary data warrants future randomized, large-scale, multi-center trials that evaluate clinical outcomes, such as the incidence of atrial fibrillation and myocardial infarction, and to confirm the effects of this therapy on post-operative morbidity and mortality in those undergoing cardiopulmonary bypass. In fact, some preliminary meetings have already been started with a research group at St. Michael's Hospital as well as McMaster University to assess the logistics behind starting such a multi-center trial. Thank you for your time. I hope you enjoyed this study. For any questions or comments on this presentation, please reach out to Dr. Ronnie Atui at the email address posted on this slide.